Do you have a case in mind where a chart looked mild, but function and comorbid risk pushed you to escalate it early on?
Yeah, I have, especially when people come in and they don't tell you how long they've really had something, or they're not consistent with their medications. Those are always bad. Or they have other things like heart problems. Obesity also takes a toll on psoriasis, it makes it worse. So they'll come back and they're like really, really bad. And you're like, why is this surface area growing so much? And to be honest, it's also the point where it's hard. It's disheartening to have to think that you have to put on something every day, constantly, especially if it becomes a large body surface. But then they're terrified of biologics because at the end of those commercials, you see this is the side effect. So a lot of them are like, I'm not trying to do that, or even give themselves injections. So I've had places where I've had to go, okay, you can come into my office and I'll inject you.
Mm.
Even though they're supposed to go home and do it, it's fine. You can take that step and bring your patient back in, and it's saved a lot of people. Then after a while, some get courage, some don't, and it's fine. See your patient, get them along.
Mhm. How do you match biologic class to specific clinical scenarios such as nail dominant disease, concurrent PSA, metabolic syndrome, or a history of IBD?
You have to keep up on your literature, especially with the nail and palmar and scalp. IL-17 inhibitors are really great. Talus is great, especially they did a lot of the research, especially for nail pitting, palmar, and genital. And they're also great with scalp. They did a lot of specific sites in their studies. And I noticed that after they came out, other companies did the same. They also got a indication for children, which was great, 6 to 11. So did Stelara, and I love Stelara. Stelara is one of the original ones. The downfall of Taos for some people is that you have to do it more often, once a month, as opposed to Stellar, which is every 3 months. So lifestyle, because especially if you're a busy lifestyle, jet setting across the world, you're not trying to bring your biologic with you all the time.
What are your rules of thumb for when to optimize dose or interval versus declaring primary or secondary failure and switching to a different mechanism of action?
Well, that's the hard part. It used to be easier, but it's hard to change somebody from one to another because most insurance companies are like, well, we're not going to go back. And you don't want to build up like antibodies to the actual treatment once you stop the treatment. And that is a risk that you take. I've had people who even said they just want to stop to see if it gets better and go, and then you try to go back and they go, it doesn't work anymore. So before I do that, I go, why don't we put a concomitant treatment like methotrexate? It helps with the flare, brings down the flare, and then it kicks back in that biologic so it helps again. Give it 12 or 14 weeks to make sure, even if it's not totally better, that it improved before you stop them. Because then after that, like I said, it's hard to go back. And I would change class. I wouldn't go from like Cosentyx to Talx because those are
Mm.
both the same. You change that entire class of the
Mm.
medication.